So I'd just like to introduce Indy. Hi, Indy. Thank you so much for joining. So Indy Kaur is Director of Midwifery in Fernandes Hospital in Hyderabad in India. She's been in India for the last 2 years and her main roles involve with training professional midwives. She has been acknowledged for strengthening maternity guidelines, which were launched in 2018, and Fernandes Hospital has been launched as one of the lead training midwifery sites for midwifery education in India. India is passionate about reducing maternal mortality through midwifery training and respectful humanised care. In her previous role as a consultant midwife, a consultant public health midwife in Bart's NHS Trust in UK, she was a member of the East London Saving Lives group, a team leader for the multidisciplinary obstetric and midwifery training simulations. She's launched maternity clinics specifically for those women who've been exposed to sexual violence, and has even won a BMJ award for developing a pathway of care for deprived women in East London who have complex social needs. Indy, we're so pleased to have you here today. Thank you so much for taking the time to join us.
Thank you. Thank you, Kate, for such a humbling introduction. Good afternoon, everybody. I would like to thank the organizers of GLOW for inviting me for the keynote speech. I'm truly honored and humbled. It is the year of the nurse and midwife, and I'm both. I'm known as Indigit, but I like to be called Indy. And as Kate says, I'm a professional midwife from the United Kingdom. I'm now based in India after finding my purpose on an initial 2-year sabbatical, providing clinical supervision to the midwives in Fernandes and helping embed professional midwifery training. And recently, the midwifery educators training in collaboration with UCLan University. In India, each year, 35,000 women die during pregnancy, childbirth, and the postnatal period. There are 272,000 stillbirths and 562,000 babies die within the first month of life. Midwifery care has the potential to prevent many of these deaths. So I would like to thank you, and I'm just getting my slide. So my topic today is bringing midwifery care into a global movement. I will give you an overview of the work that we have done to date and how we can do collaborations to bring it even further to fruition. So Fernandes Hospital started in 1948 with 2 beds, and we have 3 hospitals providing maternity services and 2 facilities offering antenatal births a year. So as you can see from 1948 to date, how much we have grown. So Dr. Avita Fernandes took over the leadership of the hospital on her return from the United Kingdom. She was in the United Kingdom from 1983 and she came back and took over the reins in January 1985. In her journey in the United Kingdom, she had worked with professional midwives, so she knew about the role of a professional midwife. She had researched trends in maternal mortality and noted that neighboring countries who invested in professional midwives had lowered their mortality rates. Her vision was to introduce midwifery to reduce mortality rates and to start training with an initial pilot program. She had support from a UK consultant, Andy Beckenham, who helped set up the midwifery curriculum based on the ICM standards. So, the tradition of a private hospital, predominantly led by doctors attending births, caused a rethink with the introduction of professional midwives, and this fostered a new working culture between the teams. The doctors had no role models of a professional midwife. In India, when a nurse has been trained, a GNM or BSc nurse, over a period of 3 to 4 years, and she may have midwifery training for between 3 to 6 months, but she qualifies both as a nurse and midwife. Hence, practices Hence, the challenge here is to understand what the philosophy and the heart of midwifery is. This started the first collaborative working between both our countries, India and UK. Practices which were normal, like stirrups, were quickly questioned, and there was a lot of unlearning to do. The first cohort of professional midwives commenced their training in 2011. They were initially taught by obstetricians, and since then we have had a series of midwifery tutors and clinical midwives from the UK contributing to teaching and training during their annual leave. My involvement began when I was invited to speak in an RCOG conference in Hyderabad in 2014. I was petrified. I've never spoken to a huge audience full of doctors. And I spoke about midwifery subjects like pain relief in labor and positions in labor. I spent my time understanding the training and what was happening in India. This was the beginning of an epiphany moment for me. I then started volunteering for 2 years during my annual leave. And I came to India initially for a year's sabbatical, and I'm still here. So it's actually been 3.5 years. Um, I'm just trying to get my slide again. So the program, so the midwifery program in Fernandez was under the Promise acronym, making pregnancy safe, humanizing birth to train a workforce to promote midwifery. Our last cohort of trainees, we had the highest number of nurse trainees because now, after 7 years, they have seen the role of a professional midwife and what a professional midwife can do. And they were now interested in pursuing the midwifery pathway. Just to note, this is an in-house program, and the certificate is just valid in Fernandez, and they're working in Fernandez. The Indian Nursing Council then introduced a 1 year nurse midwife practitioner in midwifery, and 10 of our midwives went. We have 54 qualified midwives, and 23 of them are working in Fernandez. We have 12 trainees, and 19 are not working in Fernandez for reasons I will go into when I speak about their challenges. These are our 10 midwives who were qualified in Fernandez, and they went on to do the post-basic diploma in nurse practitioner in midwifery and have a certification that they can practice anywhere in India. So what did that mean for us? It was a phenomenal change because for 63 years, only doctors birthed. Today, 40% of the births are done by our professional midwives. What happened to the episiotomy rates as well? In India, routine episiotomies are still practiced by a large number of institutions. The midwives' episiotomy rates about 6.9%, and we're constantly working to lower that even further. And the doctors' episiotomy rate is about 21.8. Fernandez Foundation practices evidence-based practices. So initially, with routine use of episiotomies, which was happening in India, the percentage was 86%. But after the evidence was introduced, with restrictive use, it came down to 40%. But with the introduction of professional midwifery program, the rate then went further down to 28.8%. So the midwives were influencing the rates. And what happened with the impact of midwifery on epidural rates? Fernandez Hospital, Dr. Vita speaks very fondly that she felt she was being horrible to women if she didn't give them the choice of pain relief. And it was the site used for training for anesthetists to learn how to do epidural. So as you can see, in 2010, the epidural rate was 67%. And after midwifery training and midwifery support, the rate then went down to 26%. So women who were on epidurals has reduced because they are now learning how to use the concepts of professional midwifery. And we all know that mobility and hydrotherapy, along with water births, reduces the need of epidural analgesia. So the midwives practicing their women-centeredness. The midwives are slowly, when we started initially, the midwives did antenatal clinics with the associated consultants. But today, the midwives, since February 2019, since 2 years ago in 2017, have done the independent midwifery clinics. And women are asking for the midwives. Some women who've been through midwifery care remembers the midwife for continuity, and we try to get that continuity going again. So we're trying our best for a hospital with large volumes to introduce midwifery. We do not have enough of midwives, so as a result, we are training intrapartum nurses whilst we continue with midwifery training. And we are also training a young group of additional labor support, so no woman is left alone. And these are our midwives and doing the clinics independently. And if you look at the picture on the bottom, that's one of our midwives that had actually come from the remote village. She could not speak English, but when she came to Fernandez, she learned how to speak English, and she's one of the best midwives, and women love her. So it's so nice to see the transition and the change in the midwives. And our midwives are becoming more confident. We have a group now of 2 doulas as well. And between the midwifery, doulas, physio team, it's a very close-knit team that helps mothers and try to personalize and individualize care, especially to vulnerable women who have fear of vaginismus or fear of birth. So we try very hard to offer that one-to-one to vulnerable women. So the midwives, this is one of the pictures of a mother enjoying her hydrotherapy. We started water births in Fernandez in February 27 after training. My colleague Astrid Osborne and myself, both consultant midwives, we did the initial training with practice drills. And to date now, we've had 130 water births and 248 hydrotherapy. And also they continue to support mothers through this COVID period and offering them water births. So we're very proud of what our midwives are achieving. And as Tina said, is during this COVID times, midwives are the ones that are there for women. So some feedbacks from the mothers. The midwives encouraged me. And she managed to have a birth because she felt it was a midwifery support. And I got what I wanted. My choice was respected. And this whole theme is about respect and how we care for women and support. And women were being listened to. Women were offered to birth in positions of their individual choice. It was very interesting when we started the training, because then the doctors also started coming into the rooms because they have never seen a birth then off the bed. So doctors were intrigued when they saw mothers on all fours, standing, birthing on their side. And it was amazing. And the doctors would come into the room if they knew the mother, because we were very, very strict, as we are midwives. And nobody could just walk in the room unless if you were invited or the mother knew you. So we tried to push that element and concept, which we felt was so important. So our midwives, when we started training, midwives and doctors did separate training. They did not train in collaboration. So we started initially skills and drills, and it was the first time that the doctors and midwives trained together. Now that was a very important step, because then it's the culture of seeing each other as colleagues. It's very hierarchical in India. The doctors are seen at a different level, and the midwives need their confidence to be developed, to see the doctors as their peers. And this is what we are working towards. And in the training, our midwives attended the RCOG workshop, and these are 4 of them speaking and presenting papers. And they were training a group of doctors in the workshop, and they were very excited that they had doctors in the group listening to them, practicing obstetric emergencies and how do you do this. So that created a spark and got them more interested and understanding what an important role it is to be a midwife. And following my connection back in Ely in London, East London, saving lives, the team of obstetricians and midwives and anaesthetists came out to India and did multidisciplinary obstetric and midwifery simulation training. But we were very keen that the training needs to be done and have trainers from within to take the training forward. So each and every one of the midwives and doctors that were trained, they then in turn went to the public institutions and cascaded training in the public institutions and even went to the RDT hospital, which is about 250 kilometers away from Hyderabad, to share what they have learned. And that created a huge community between the doctors and the midwives. And that is Kate and myself, a colleague from the UK who's gone back to the UK now. But I shall share more about what Kate and I did. So our pride and wonderful moment came when we felt that we were in a position, after starting midwifery in 2011, to have a midwife-led unit. So the midwife-led unit was created after 9 years of training professional midwives. It's it's a co-located birth center, and the midwives were thrilled. Um, the guidelines were developed in collaboration with our obstetric and neonatal lead because we wanted their support and to be involved. And we also had several trainings of neonatal resuscitations, and if you need to transfer, how long would it take? So everybody was happy and everybody felt it was safe. So that was a big moment for us. We used concepts of the Mums Network and women, and invited women to have a look at the unit. And these are some of the pictures. The door was very symbolic. We were very, very keen to have that door. We were asked lots of times, why do we need that door? And we said, no, that is a very symbolic door that demarks the difference. And if our mothers need to come over, then even for a CTG, she then goes over. So we were very clear. So the roles and the scope was very clearly defined. And we had a pool room, and we tried to have the concepts of home to home, and we tried not to have a bed but a normal bed in one of the rooms as well. We got the cup and the rebozo, the gym balls, and the statistics. We opened that in July 2019, and in June 2020, we had about 250 women. We could still improve on it, and there's still loads of work to be done. The co-located birth center is in the old city, so we do have a percentage of generations that have birthed in Fernandez, and generations have known the doctors. So, but they are still now beginning to ask for professional midwives, and a lot of women in the old city are traditional Muslim women, and they too are asking for water births. So we're very pleased that it's not just, it's for everybody, and we're pleased that that has come through. So these are what the midwives are doing, with complementary therapies, and to encourage mothers to birth in positions of their choices, and support, and even hydrotherapy and water births. Our biggest transfer from the midwife-led unit to the obstetric unit, the main two transfers are the request for epidural analgesia and thick meconium stain lico. So those two were our biggest transfers. And the mode of birth, as you can see, 89% of women had spontaneous vaginal births, 19 had assisted births, but that was in the obstetric unit, and 7 of them had cesarean section births. We're very, very pleased as well that the different positions and offering mothers different choices. And we're very proud of that because no mother is birthing on her back. The neonatal resuscitation that was required was 4%. And our midwifery reviews, this is where we need to increase more mothers coming to see a midwife initially. Our vision in Fernandez, when we have even more midwives, is to have every mother see a midwife. And we are working hard on that, and we need to increase our midwifery numbers. So, what are our challenges? So, our midwives are the only breadwinner. They are keen, they desire to progress, and language is their barrier. They lack the confidence in articulating in English, but their thirst of knowledge is there, and they're not sure how to get better. The midwifery students are very different to the midwifery students back in the UK, and I can see the hunger and the thirst. The midwives comes from families who are daily wage earners, and the families want their kids back. The extent of poverty is huge, and every penny, every rupee, I would say, that's earned goes back to support the family. The families can't see any value in education because they can't bear the thought of their daughters being unmarried. That is a huge cultural barrier because a lot of our midwives are pressurized to leave and to go and get married. And it's very difficult to fight the system. And during this recent COVID period, we had a lot of nurses and midwives leaving because their parents wanted them back. So it's a huge challenge for them. I'm just getting to my next slide. So, what happened next? So, based on our professional midwifery education training program, we were then visited by the health minister and approached by the government of Telangana. And this was the beginning of our first public private partnership with Fernandez and UNICEF. And if you could note what the nurses are wearing here, and it was amazing. One of our biggest challenge that was given to us by the commissioner of Telangana, she said to Dr. Avita, I have no doubt you would create professional midwives, but what I want is the respectful care to be cascaded across. And our 18th month curriculum that we did was based on respectful care from the beginning to the end in every clinical competency. The training was 18 months and it was based on global standards. We looked at the ICM standards and developed that. And I must say, the Fernandez midwives played a phenomenal role during this program. They worked alongside with us and they also stayed with the midwives 24/7. It was a residential program. It was overseen by myself and then Kate Springer, who joined us after 6 months into the start of the program. And if you look at the next slide, this is how they look at the moment from the white suits that they were wearing. And they're very proud of their suits. Word then went around where they were training. If you want to have a normal birth, go to that hospital. They wear pants and the pants and suit girls is what they were called. And it was such a moment from how they were and how they are now. We had a lot of collaboration. Dr. Sheena Byram, Sean Walker. So there was a lot of collaboration and work between the two countries. And we value that. And these are the scenes that you would see. So the respectful care women-centered approach was translated throughout the program. And this is involving companions, and it's the first time you would see a man in the room. So that created a lot of ripples that, oh my God, the husbands are now being allowed. But it was the mother's choice. If she wanted a husband, we had to work around it for the sister to let the husbands and also supported the nurses on why it was important. So the training was not just done with the trainees. The nurses who were there were very interested when they saw the different positions and what and how the midwives were interacting with women and their families. And mothers, the mothers were so delighted. These are three mothers that were practicing moving around, and they were completely amazed. They were completely amazed. And when some of them were second time moms, and they said that they were birthing on their backs. So they knew, they were prepared that when they were in labor, they did not need to lie down. They could move around and it will shorten the labor. So everything was shared with them, and it was such an exciting moment for us. And this was the smiles that we were seeing. And we had to teach them everything from the beginning. Now, they had a lot of unlearning to do because this group of trainees were already birthing. And when they did this program, one of them said, "Oh, ma'am, you're teaching me to do nothing." But what I was trying to teach them to do was not to interfere, but to watch and see and listen to the mothers, look for cues, look for signs, and learn about the transitional stage. And this picture, the eye contact, and we had to teach them that it was okay. But this group of trainees as well, they said to us that they were never treated in this way. The training was different. We were respectful to them, and they weren't used to that. So these were the scenes that we developed, and even during labor, the husband came in as the birth companion. Um, so what happened in the training? So in the times when we started in this hospital, it was chosen because the cesarean section rates were very high, and the birth rate went up from 23% to 33%, and the cesarean section rates went down from 77% to 67%. I know it's 10%, but it is a really, really important that we managed to do that. And when they moved to the second site for the last 6 months of their training, they reduced the episiotomy rates from 46% to 21%. And these are routine episiotomies, and the birth rates were about 63 to 66%. That's normal vaginal births. Now, if you look at this picture, in India, squatting on the floor is a very social event. It's very accepted. And the expressions of the mothers, and this was one of our midwives talking to the mothers and giving them antenatal education and empowering them and telling them that if they've had a previous section, we can help them to have a VBAC. So all these discussions were happening, and the mothers were very excited, and they were very happy to see the midwives. So the trainees also had a lot to unlearn, and some of them did confide that they were a bit disrespectful, and they know that now it's wrong and how disrespect affects the mother. We actually had mothers that were asking us, "Why are you being kind to me? Because I was beaten and abused during my first birth because I'm HIV positive." So there was a lot of things that really hit hard. But the trainees then understood, the importance of privacy, environment, compassion, and how to actually show empathy and introduce yourself and ask consent before you do anything. In the last 6 months as well, no women birthed in a lithotomy position. And I can't say any more about that. We were very, very happy that they got it. Um, and what we did was we actually worked alongside. We went to the government institutions and worked with them because the trainees needed to see what a midwife does. One of the biggest challenges in India was the midwifery tutors. They did not have the clinical background, and they were unable to translate the theory to practice. And this is one of our biggest challenge up to today, because midwifery is seen as a pathogen, and is so medicalized, and we need to change that. We need to change the whole curriculum to see birth as a normal physiological event. So this was a huge challenge, but working alongside with the trainees, when they saw by example how you would communicate with mothers and how you would use the principles of midwifery, and that helped. And also our Fernandez midwives, they were there, as I said, and lived with them 24/7. One of the trainees fed back, there's no discrimination and everybody is treated equally. Um, And the training was also evaluated by an external public health team, and they fed back that they were very interested that and impressed with the changes in attitude and how women were treated with respect, and they asked for consent. When we said in the training, you need to introduce yourself. And they say, ma'am, but there's so many women. I says, yeah, but you need to introduce yourself to each and everybody. So that was ingrained, and empathy then came through. Um, and we had a huge support. Our Deputy British High Commissioner, Dr. Andrew Fleming, who oversees Hyderabad and Andhra Pradesh, he heard of what we were doing, and he actually came out to see the midwives and to see the training that we did. And that was a collaboration, the UK-India Living Bridge. And when the midwives qualified, he did invite them to his residence and had a huge party with the Countess of Wessex. So it's the first time our trainees and our midwives used royalty. So they were very excited. You know, they thought it was the Queen. So what have they done now since after the training? So the midwives are doing childbirth sessions, and there's a community awareness. People around the community and the health centers are beginning to realize that there's something different happening, and the birth rate, normal births are going up. And the important thing is they mentored the other nurses for respectful care and how you could do it. And so these are some of the pictures of what they have done now. They've gone back to the periphery of Telangana, and some of them are in the rural belt. And these are some of our midwives, and they are training the ASHA workers. The ASHAs are accredited healthcare social activists, and they play a huge part in supporting women, families of women in the community, and they are key. So the ASHA workers, when they knew the antenatal care and how we supported women, that we were not being cruel by not giving them a drip, by letting them mobilize and to give birth in different positions. They needed to understand it first, and then they could endorse it back to women. So that was very encouraging to see the midwives doing that. And of course, like to practice the different mobility and to do the half squats. So in India, everybody, when I started, they would say, do you have an Indian toilet or a Western toilet? And then I realized very quickly it was the squat and the movement. And these are our 30 midwifery students currently, all happy and excited with what they are doing. So this then created, when the trainees, the landmark thing was when the government endorsed the guidelines on midwifery services in India. It was a very exciting time because we were part of the task force for many meetings, deliberating over the curriculum, including working with ICM, WHO, INC, and the other NGOs. And the great news is the government of India has committed to an additional 85,000 midwives by 2023. So we were also then asked to train the nurse midwifery educators training. That program started in November 2019. The program was halted in March, on March the 25th because of the lockdown, and the trainees were asked to go back to the state. But we continue to do online lessons with them and keeping in touch with them in that way. And this was at the opening ceremony, and that's Mr. Dilip Kumar and the ex-deputy High Commission and Andrew Fleming in the opening ceremony. But at that meeting, an announcement was made. And what was the announcement? And this was the most exciting part, to recognize midwifery as a unique profession. So that was a real breakthrough. And to create a cadre of nurse midwifery practitioner. And now we know that the initial midwifery program that was for 12 months, the INC has agreed for it to be 18 months. So that's a real breakthrough. And most importantly, they are going to rename it the Indian Nursing and Midwifery Council. Currently, it's the Indian Nursing Council. So that's going through Parliament. So it's really exciting times for us in India, and to have a scope of Nursing and Midwifery Act. So we've come a long way. The leadership of the government in pushing this through, it's really important. And these are our groups of midwifery educators, tutors. They have gone back now too because of the COVID. And our 30 nurses who are training to be midwifery educators come from the 5 states around India, which is, as you can see, where they're from. And they're all MSc qualified. And this was a big decision. We felt that a GNM who had years of experience, who had the aptitude, so there's a lot of ideas being shared with recruitment and selection. So what's happening in India? The White Ribbon Alliance did a huge survey, and what women want is very simple. Women want to be treated with respect. Women want to have clean facilities. Women, there's it's simple things. Women are not asking for a lot, but they want to be treated with respect, to have water and sanitation. And this is how respectful care became a lobby for us. So it's exciting. It's exciting to be part of the revolution. And we have a women's group like the Bangalore Birth Network, who helps women and families make informed decisions about their births and support during the postpartum period. We were scheduled to have a normal labor and birth conference, and we plan to do that online after this exciting GLOW. So from my perspective, UK is involved, but we need to collaborate with online classes and with other countries. So to conclude, we know that midwife trained to global standards. The global standard and collaboration will transform maternal care in India. But collaborative research is also one way of placing India globally with the rest of the world. But safe and effective care can avert, we know, to 83% of maternal deaths, stillbirths, and newborns. And professional midwives will also impact on unindicated cesarean section rates in India, which is as high as 70% in our state in Telangana. And we have the government of India's leadership now in committing it. We have seen too much too soon, Sue Ann Miller had highlighted in The Lancet, and too little too late. So let us embrace and work together in supporting the global change with our colleagues from low and middle income countries. I thank you very much for listening to me. Thank you.